I want to tell you about a patient I still think about. She was 71 years old, sharp, active. She gardened 3 mornings a week, walked her neighborhood every evening, and had no major risk factors on paper. No uncontrolled blood pressure, no atrial fibrillation, no prior warnings. She came to me for a routine follow-up. We talked about her memory, her energy, her sleep. Everything seemed fine. 3 weeks later, she woke up unable to lift her right arm. Stroke, overnight, no warning she could feel. When we pieced together what had happened, one detail kept surfacing. A positional detail. Something she had been doing every single night for decades that had been quietly compressing a key artery feeding her brainstem for 6 to 8 hours at a stretch, while she slept completely unaware. That detail is what this video is about. Because here is what most people do not realize. Stroke risk does not only build during the day. For many seniors, the most dangerous hours are the ones they spend unconscious. And the position your body is in during those hours is not just a comfort decision. It is a neurological one. In the next few minutes, I am going to walk you through 4 sleeping positions that quietly raise that risk, and 4 that work with your brain's biology instead of against it. But before we get to the positions themselves, I need to show you what is actually happening inside your brain while you sleep. Because without that, the positions are just a list. With it, they make complete sense. Most people think about sleep position the way they think about a mattress preference. A comfort issue, a back pain issue, maybe a snoring issue. It is actually a vascular and neurological issue. And once you understand why, you will never look at how you sleep the same way again. Here is what is happening inside your body every night while you sleep. 2 systems are working, or trying to work, on your behalf. The first is your arterial blood supply to the brain. Your brain receives blood through 2 sets of arteries, the carotid arteries running up the front of your neck, and the vertebral arteries running through the bones of your spine. These vessels are not rigid pipes. They are living tissue, and in seniors with stiffer vessel walls, they are more sensitive to external pressure. Certain sleep positions compress these arteries, partially, not completely, for the entire duration of sleep. 6 hours, 7 hours, 8 hours of reduced oxygen delivery to the brain, night after night, accumulates into something significant over months and years. The second system is one that most of my patients have never heard of until they sit across from me in the clinic. It is called the glymphatic system. Think of it like a night shift cleaning crew for your brain. While you are in deep sleep, the spaces between your brain cells expand by roughly 60%, and cerebrospinal fluid rushes through, flushing out the toxic byproducts that your brain produces during the day. Proteins like amyloid-beta and tau, which are directly linked to Alzheimer's disease and vascular dementia. The critical thing to understand is this: the glymphatic system is highly sensitive to your sleep position. The wrong position does not just reduce comfort, it locks the doors on that cleaning crew. The waste does not get cleared. Night after night, it accumulates. Now add one more layer. In seniors, blood pressure shifts significantly during sleep, particularly in the early morning hours when it surges as the body prepares to wake. If your arteries are already partially compressed by your sleep position, that morning pressure surge hits a system that is already under mechanical stress. That is the combination that creates risk. This is not about fear. This is about understanding a system that is already running inside you every night, and then deciding whether to work with it or against it. Let us look at the 4 positions that work against it. Position 1. Stomach sleeping. I had a patient in his late 60s who had been a stomach sleeper his entire life. He came to me after 2 transient ischemic attacks, what people call mini-strokes, within the same year. His imaging showed early arterial wall changes that were consistent with chronic positional compression. He was otherwise healthy. His cholesterol was controlled, he did not smoke, he exercised regularly. When I asked about his sleep, he described the classic stomach position: face turned to one side, arms tucked under the pillow, chest flat against the mattress. Here is what that position does to the body. When you turn your neck 60 to 80 degrees to one side for hours, you are directly compressing the vertebral arteries that feed your brainstem. These are not small vessels. They supply blood to the parts of your brain that control balance, coordination, consciousness, and basic autonomic function. Reduced flow through them overnight is not trivial. At the same time, lying face down presses your chest into the mattress. Your diaphragm cannot move freely. You breathe more shallowly than your brain needs. Oxygen saturation drops gradually across the night. In a younger person, with elastic vessels and strong respiratory muscles, the body compensates. In a senior, with stiffer arteries and reduced lung capacity, that compensation is incomplete. The position also loads the cervical spine, the bones of the neck, in a sustained rotation that it was never designed to hold for hours. Over years, this contributes to the arterial wall changes I saw on my patient's imaging. Not dramatic changes, quiet ones. The kind that build towards something serious. Position 2. Tight fetal curl. There is an important distinction I want to make here before I describe this position, because I do not want you to overcorrect. A gentle side curl is fine. What I am talking about is the extreme version: knees pulled tightly to the chest, chin tucked down toward the sternum, shoulders rolled inward. In that tight position, 2 things happen that concern me neurologically. First, the extreme spinal flexion compresses the chest cavity and restricts diaphragm movement. You breathe shallowly all night. For seniors who may already have undiagnosed sleep apnea, and many do because the symptoms are subtle and often written off as normal aging, this position narrows the airway further and deepens the oxygen dips that occur during apneic episodes. Second, the chin-to-chest posture can partially compress the jugular veins, which are responsible for draining venous blood out of the brain. When venous drainage is reduced, pressure inside the skull rises slightly. Over a full night of sleep, that matters. I saw a woman in her mid-70s who came to me with recurring morning confusion that cleared by mid-morning every single day. Her family had started to worry about dementia. We eventually traced the pattern to her sleep setup: a tight fetal position on a pillow that was far too high, forcing her chin toward her chest for the entire night. Her symptoms resolved within 2 weeks of changing her position. She did not have dementia. She had a drainage problem that was correcting itself every morning once she sat upright. Position 3. Flat back with no elevation. This next position is the one that surprises most of my patients, because on the surface, it sounds like the safest option of the 4. It sounds like the position that puts the least stress on any structure. For certain seniors, it is the most dangerous position of all. Here is why. When you lie completely flat, gravity pulls the soft tissue at the back of the throat, the tongue, the soft palate, the surrounding musculature, directly backward. This narrows the airway. In seniors with any degree of muscle laxity, which increases naturally with age, this is the primary driver of obstructive sleep apnea. And obstructive sleep apnea is not just a snoring problem. Untreated, it creates repeated cycles of oxygen deprivation throughout the night. Each episode triggers a blood pressure spike, an inflammatory response, and activation of the clotting system. These are three of the most well-documented precursors to ischemic stroke. I want to be precise here, because flat back sleeping is not dangerous for everyone. If you are a senior without sleep apnea, without significant hypertension, and without known carotid disease, flat back sleeping carries a different risk profile than if you have one or more of those factors. But in my clinical experience, many seniors who sleep flat do not know whether they have sleep apnea. They have never been tested. Their partner tells them they snore, but they assume that is normal. It is not always normal. It sometimes means their brain is being deprived of oxygen for minutes at a time, repeatedly, every night. Position 4. Right side sleeping with the arm tucked under the head. This one requires precision, because I am not saying right side sleeping is dangerous. I am saying one specific variation of it is. The distinction matters, and I will come back to it. The arm tuck is the problem. When you sleep on your right side with your arm pulled under your head, two things happen simultaneously. The arm position rotates the neck and elevates the shoulder on that side, which compresses the carotid artery against adjacent tissue. And the right side position itself places sustained pressure on the inferior vena cava, the large vein that runs along the right side of the spine and returns blood to the heart from the lower body. Prolonged compression of that vein slows venous return and increases the workload on the heart overnight. Right side sleeping without the arm tucked under the head is a different conversation. It is not the optimal position, but it does not carry these specific risks. If you sleep on your right side with your arm resting forward on a pillow in front of your chest, the carotid is not compressed, and the venous return issue is significantly reduced. I want you to hear that clearly, because I do not want you to panic about a position that, in its modified form, is acceptable. The arm tuck is what changes everything. And here is what I want you to notice across all four of these positions. The risks are not dramatic. They are quiet, gradual, the kind that do not announce themselves until one morning they do. Which is exactly why the four positions I am about to describe are worth setting up carefully tonight. This is where I want to focus our attention, because knowing what not to do is only half of it. Let us talk about what actually works and exactly how to set it up tonight. Position 1. Left side sleeping. This is the position I recommend first to almost every senior I see in my clinic who is concerned about brain health and stroke risk. There are 3 reasons, and they all reinforce each other. First, your heart sits slightly left of center in the chest. When you sleep on your left side, you are reducing the mechanical workload on the heart overnight rather than pressing it against the chest wall. Second, the inferior vena cava, the large vein we talked about earlier, runs along the right side of the spine. Left side sleeping decompresses it, which means venous return to the heart flows more freely through the night. Third, and this is the one that matters most from a neurological standpoint, lateral sleeping is associated with more efficient glymphatic drainage. That night shift cleaning crew works better when you are on your side. The cerebrospinal fluid moves more freely through the brain's waste clearance channels. Over years, that difference in protein clearance is not trivial. Here is how to set it up correctly. Your pillow height should keep your ear aligned with your shoulder, not dropping toward the mattress, not pushed upward. For most seniors, that means a pillow that is roughly 4 to 6 inches thick. One pillow between your knees keeps the pelvis neutral and prevents the hip rotation that causes people to drift onto their stomach during the night. Knees should be slightly bent, not pulled to the chest. I want to address the question I hear most often. Is left side better than right side? For brain drainage and heart circulation, yes. Right side sleeping without the arm tuck is acceptable, but left is where the biology tilts in your favor. Position 2. Modified right side sleeping. For seniors who cannot tolerate the left side, significant left shoulder arthritis, a cardiac device placement on the left, or simply genuine discomfort that prevents sleep, modified right side sleeping is a reasonable option. The modification is non-negotiable. The arm must not go under the head. It rests forward on a pillow placed in front of the chest. That single change eliminates the carotid compression we discussed. Pillow between the knees remains essential. This is not as neurologically optimal as the left side. I will be honest about that. But it is vastly safer than stomach sleeping or flat back sleeping for most seniors. Do not let the perfect position be the enemy of a consistently good one. Position 3. Elevated back sleeping. This position is not a universal recommendation. It is specific to seniors with confirmed sleep apnea, significant gastroesophageal reflux, or poorly controlled hypertension. If that is you, this is worth understanding carefully. A 30-degree elevation of the upper body does 3 things simultaneously. It reduces airway collapse, which cuts the frequency and severity of apneic episodes. It lowers intracranial pressure by improving venous drainage from the skull. And it reduces the mechanical strain on the heart from fluid redistribution during sleep. Those 3 mechanisms are each independently relevant to stroke risk. The correct way to achieve this is with a wedge pillow that elevates the entire upper body evenly, not stacked regular pillows which collapse by 2 in the morning and push the chin toward the chest. A small pillow under the knees relieves lumbar pressure. The critical point is that the elevation must be from the waist up, not just the head. Head-only elevation on stacked pillows kinks the neck and can partially compress the very vertebral arteries we are trying to protect. Position 4. Supported side sleeping with a body pillow. Many seniors who intend to sleep on their left side wake up on their stomach or back. This is not a willpower issue. It is muscle memory built over decades. The body returns to what it knows. A body pillow placed firmly behind the back physically prevents rolling. It works as a passive barrier through the night. Hugging a second pillow in front keeps the top arm from falling across the chest and compressing the side you are lying on. Changing a sleep position you have held for 40 years does not happen in one night. I tell my patients to give it 2 to 3 weeks. The first few nights feel wrong. That is normal. The body is adjusting, not objecting. Now I want to go a layer deeper, because the positions I just described are not based on comfort theory. They are based on a growing body of evidence that most seniors never hear about in a standard appointment. The glymphatic system I introduced earlier has been studied extensively in animal models, and one finding comes up consistently. Lateral positioning produces more efficient cerebrospinal fluid flow than either supine or prone positions. The side-sleeping brain clears waste more completely during the same hours of sleep. That is not a small difference over a lifetime. In human studies, the pattern holds in a different but important way. People with neurodegenerative diseases, Alzheimer's, Parkinson's, mild cognitive impairment, are significantly more likely to spend long stretches of the night on their backs than cognitively healthy controls. One study found they were nearly 4 times more likely to spend more than 2 hours per night in the supine position. The direction of causality is still being studied, but the biological mechanism we discussed gives that association real weight. Here is what makes this compound over time. Amyloid-beta and tau, the proteins the glymphatic system is designed to clear, do not accumulate dramatically overnight. They build slowly, across years, in people who never feel a symptom until they do. Neurotoxin buildup from impaired sleep clearance can precede cognitive symptoms by 15 to 20 years. That means the nightly choices made at 60 have consequences that show up at 75 or 80. Now layer the vascular risk on top of that. Chronic positional compression of the vertebral or carotid arteries reduces oxygen delivery over 6 to 8 hours a night. This is not one bad night. This is a nightly accumulation that over months and years stiffens arterial walls, promotes the conditions that allow microclots to form, and raises the baseline stroke risk profile quietly, without symptoms. And then there is the morning surge. In seniors, blood pressure rises sharply in the early hours as the body prepares to wake. Cortisol increases. Heart rate picks up. For someone whose arteries have been mechanically compressed all night, that biochemical surge arrives on top of an already stressed vascular system. I had a patient who asked me once, "Why does this matter if I feel fine in the morning?" I told him, "The brain is remarkably good at compensating. What we are trying to prevent is the night it cannot compensate anymore." If you snore, or if you wake unrefreshed despite adequate hours of sleep, that warrants a conversation with your doctor. Untreated sleep apnea, combined with a poor sleep position, is the highest risk combination I see. Each one amplifies the other. Let me give you exactly what I give my patients before they leave my clinic. Tonight, choose one position, either left side sleeping or elevated back sleeping, depending on which risk factors apply to you. Set up your pillow configuration before you get into bed, not after. This sounds small. It matters. When you are already drowsy, you will default to whatever is easiest. Make the right setup the easiest option. For left side sleeping, pillow height that keeps the ear aligned with the shoulder, one pillow between the knees, arms resting forward rather than tucked. For elevated back sleeping, a wedge pillow from the waist up, small pillow under the knees, head in a neutral position. In the first week, expect discomfort. Your shoulder, hip, and neck muscles have adapted to your old position over years, possibly decades. You will feel the new position. That feeling is muscle memory adjusting, not a signal that the position is wrong. Most of my patients report that by day 4 or 5, the initial stiffness begins to ease. If you are rolling during the night, and many people do, especially in the first 2 weeks, add a body pillow behind your back at the start of week 2. It does not need to be elaborate. A firm bed pillow works. The goal is a passive physical barrier that prevents rolling without waking you. Check your pillow height at the end of week 1. If your neck feels strained in the morning, the pillow is either too high or too low. Ear aligned with shoulder is the reference point. A few specific situations I want to address directly. If you have gastroesophageal reflux, the elevated left side position combines the benefits of both lateral sleeping and upper body elevation. If you have a history of atrial fibrillation, left side flat or elevated is appropriate. If you have cervical arthritis, a body pillow supporting both the front and back reduces neck strain in any lateral position. And if you suspect sleep apnea, if you snore heavily, wake with headaches, or feel unrested despite sleeping 7 or 8 hours, positional change alone is not sufficient. You need a sleep study. Position is one lever. It is not the only one. One of my patients called me 3 weeks after we had this exact conversation. She said she was sleeping through the night for the first time in years. Her morning blood pressure readings had come down. She had not changed her diet, her medications, or her exercise routine, just the position. But here is what I told her when she called. I said, "This is a good start, a genuinely good start. And now there is something else we need to look at. Because sleep position is one door, and you have just learned how to open it. But in my clinic, I see patients who do everything right at night, and then walk into a situation during the day that quietly undoes the progress they made while they slept. Most of them have no idea it is happening. Some of them have even been tested for it and told everything looks fine, when the test itself was the problem. There is one more thing I need you to know, and it is the reason I do not want you to stop here. The glymphatic system we talked about clears waste during sleep. But what accumulates during the day, and whether it is being caught early enough to act on, is a separate problem. And some of the most widely used tools for measuring that are giving seniors a false sense of security, catching things too late, or measuring the wrong things entirely. I have watched patients do everything right at night and still miss a window they did not know was closing. Not because they were careless, because nobody told them what to question. The next video addresses exactly that. It is on screen right now. Click it while this is still fresh, because the progress you started tonight is worth protecting, and that video is where the protection continues. The patients I worry least about are the ones who keep going.